amount of talent and smarts and a lot of education on this stream here, and folks are going to really dig into a real heavy conversation, and a conversation that that we felt is going to be one that's on the come up, right? Like, I would assume a month or two from now, a lot of people are going to be talking about this, and this is something we wanted to broach as part of the Black Health Now initiative immediately, really, to just again, have the conversation. I'm also excited for a few other reasons, in that my colleague and counterpart, Wally Holloway, who is our associate managing partner here at TBWA World Health, is joining me this evening, and that's really dope. But the sad news is that, unfortunately, this is my last stream hosting the Black Health Now initiative. So I'll be handing it off to Wally, and of course my other colleague Brian, who, look, trust me, folks, you're in good hands. So that being said, we're going to just dig in. First, we're going to do some introductions to get an idea of who these experts are in the room. And then we're going to hand it over to Wally, allow her to kind of kick this off. And look, we're going to have fun here. We're going to have great conversation. If people have questions, please throw them in. Myself or Wally will take them, make sure that we ask them. And we're just going to dig in here and just talk, right? So this is like us at a bar, randomly sitting down and having a good conversation. So that being said, who wants to start? Like, who's gonna kick it off here, or should I pick? All right, Dr. Millett. Oh, unmute.
Oops, unmute. Yes, I gotta get used to this. So hi everyone. Good evening. Buenos tardes. All that good stuff. So my name is Dr. Arabia Millett. I am a Cuban-trained physician. I am an emergency physician, meaning that I specialize in emergency medicine and trauma. I was born and raised in New York City. And yeah, I'm an ER doctor on the front lines. I also teach and work. I teach emergency medicine and work in various parts of West and East Africa, and as well as multiple parts of the Caribbean. So I'm here to support everyone and to speak about COVID and COVID-related things. And brace yourself, because I had a long day. So forgive me if I stumble across my words. Send your prayers.
All right, Dr. Ratson.
Is that
I think you're mute.
I'm on mute. Okay.
Now you're not.
Good evening.
Thank you.
People who are watching this live, and I'm Scott Ratson. I'm a public health physician. I'm based at the City University of New York School of Public Health and Health Policy. I've been engaged editing a Journal of Health Communication, and through this we've been running a tracking survey and doing all sorts of pieces to see not only how New Yorkers feel, but also to try to understand the realities of health, and Black health, white health, all health. And reality here is that tonight I hope to have, as you're saying, Walter, and thank Wally for the invitation, to show a way that we can think about, it's not just the messages of what we give, but it's also how we do it and how we tell stories and the reality of health communication. So I'm happy to be here and looking forward to this discussion.
Dr. Levis, do you want to go next?
Sure. My name is Thomas Levis, and I am also a New Yorker from the Brownsville section of Brooklyn, New York. And I'm currently living here in the South. I'm Dean of the School of Public Health and Tropical Medicine at Tulane University, and also co-chair of the Governor's Task Force on COVID-19 and Health Equity for Louisiana. Before coming here, I've been here about 2 years. Before coming here, I was at Johns Hopkins, where I was the director of the Center for Health Disparities Solutions for 25 years. I'm looking forward to this conversation.
Well, we're glad you're here. Dr. Colbreth.
Hi, I'm Carissa Colbreth, Medical Director for Infectious Disease Diagnostics at TriCore Reference Labs in Albuquerque, New Mexico. And we've been involved in the COVID-19 diagnostic response for the state of New Mexico since the beginning of the pandemic. And I'm really glad to be here to talk to you all today.
Thank you. And Dr. Radin.
Hi, my name is Dr. Radin, and I'm an epidemiologist in Scripps Research in La Jolla, California. And my research has focused on vaccine effectiveness for a number of different respiratory viruses, and as well as digital medicine research. So finding new ways to incorporate wearable devices to improve our ability to detect viral illnesses in populations.
Well, again, thank you all for being here. This is amazing. We've got the heavy hitters and the experts around COVID, and this is an important conversation. As everybody knows who saw our flyer, you know, COVID is top of mind for all of us right now because obviously we're in the middle of a pandemic, but there's another conversation that's starting to bubble to the top, right? These vaccines will hopefully be available in the coming months, but as we know, the development time on all of them will probably be significantly reduced from typical vaccines. So as a result of that, a lot of people are talking about skepticism. Do I take it? Do I not? Are they going to be safe? But that's particularly relevant for the Black American community, especially given its history with, you know, horrific medical experiments that have been conducted on Black people throughout history, all in the name of science. So this in particular is really impacting Black American perceptions of this vaccine that's coming up. And this crosses a spectrum, young people, old people we've heard it from, and across all income and educational levels. So with that, I want to kick off this conversation. And really the first question is, how do we think that this historical treatment and the perceptions of the Black community around the healthcare system in general and the disparities has really shaped their perceptions of the vaccine? Who wants to jump in first and take that one on?
Okay, I guess I'll say something.
Dr. Millett, yes.
So we all know that Black America, or Black Americans for the most part, has a huge mistrust of the medical system or the entire healthcare system historically, as we know that we have been experimented upon during the Tuskegee syphilis experiment, Agent Orange. I mean, we could even go into the Guatemala sexually transmitted disease study that actually took place here in the United States as well as back home in Guatemala. And remember, there are Black people in Guatemala as well. And also Puerto Rican women, Afro-Latinas here in the United States as well, that were sterilized unknowingly throughout the United States, especially parts of down south and even in the island of Puerto Rico. So of course, with the skepticism that many of us, including myself, I'm an emergency physician. I was on the front line in Brooklyn, as well as in the South Bronx. The hardest hit area in Brooklyn was East New York and Brownsville, and as well as in the South Bronx, that I also have skepticism, knowing the history, understanding what current administration that we are under right now, and the amount of the misinformation that was constantly disseminated across social media, as well as other various media outlets. So it is to be expected that many of us are skeptical about the vaccine or the production of the vaccination, but there are ways that we can further discuss on how we can make sure that this vaccination can be safe for us and non-toxic as well, and also made available to us. And we also need to understand that Blacks are also severely underrepresented in clinical trials for various reasons, whether if you talk about the mistrust coming from the Black community towards our healthcare system, and then also from the healthcare system, not really, really caring too much what we think and how we can benefit from treatment as well. And also knowing that we also receive subpar care. And so, of course, that's going to definitely impact our community at large. And again, I also have skepticism as well. And this is coming from a physician that's on the front lines in New York, the former epicenter.
I'd like to pick up on one of the points, which is that the source of the distrust that African Americans have is often, we often hear it as being referred back to the Tuskegee syphilis experiment. And clearly this was a horrific experiment that was done, but in no way is Tuskegee the source of this distrust or the only source of the distrust. The distrust has been there before Tuskegee, and it's been after. We recently I did a study a few years ago where we looked at the question of how much people knew about Tuskegee and to what extent was Tuskegee the source. We found that the majority of African Americans had never heard of the Tuskegee syphilis study. And then among those that said they heard about it, we asked them questions about it, and very few of them had accurate information about it. So they knew very little about it, even those that had heard of it. The distrust comes from untrustworthy behavior, including contemporary untrustworthy behavior, People know about their friends and neighbors that have been mistreated, that have been treated disrespectful ways. They've had personal experiences of that type. And so it's not, so this idea that it's, oh, we did this one thing and they just can't get past it is problematic, because it allows us to not look at what we're doing currently and how some of the things that we do now help to stoke that distrust. And I'll give you one example. We have this program called Operation Warp Speed that the federal government has deployed to try to create a vaccine in warp speed. We have an expert here in health communications. I'd love to hear his thoughts about this. But it seems to me whoever came up with that term, I truly hope is not someone that was trained at any accredited school of public health in this country. No person with even the most basic training in health communications would have called an operation like this warp speed. What does warp speed mean? It means we're going to make it fast. Well, fast means rushed, fast means hurry, fast means you're going to cut corners, fast means that you're going to put it out there before it's safe, and therefore people are going to be less likely to take up the vaccine that we need to get through this pandemic. So there's a lot going on here. There's a lot of misinformation. There's a lot of inaccurate information, including inaccurate information coming from the federal government itself. And the fact that the federal leadership has been so poor in terms of the quality of the health communication has played a big role in stoking the distrust that we see in the surveys that we're currently doing.
Yeah, I totally agree about the issue of where the mistrust is coming from, because while it certainly originates, and we have a lot of history of mistrust over time, but there is active mistrust that's generated anytime somebody experiences healthcare. We know the data about African American women still dying during childbirth at disproportionate rates. We know the data about African Americans not being perceived as experiencing pain in the same way as white Americans, and so they receive less pain medication. So the distrust is happening and it's active, and we see the disproportionate health experiences that happen in the Black community that have only been highlighted by the pandemic. So we are experiencing a pandemic that is showing us the errors in healthcare. However, we have to then rely on those same individuals that we perceive to have caused the current trauma that our communities are experiencing to now provide the solution. And that creates a dangerous cycle. And I think we'll start to get into the communicators of this information being trustworthy sources in the community.
If I could pick up on both of those, I think Dr. Levesque said it very well, of the distrust that we have in government. And I'm a believer in good government and prudent policymaking. My other degree is from Harvard at the Kennedy School of Government. And the belief was that we need good, prudent health policy with both access, equity, and all the other pieces that go into a functioning health system. Unfortunately, as we know, we don't have that. So as we see the distrust go down generally in government, and then we see it affect the vaccine generally as well. Before even COVID, we had measles vaccine drops, we have anti-vaccinators, we have misinformation and disinformation, those are different. And we have now erosion in the systems that we should have to address this. So to address your question directly on warp speed, you're absolutely right. It's crazy to think that was chosen by anything more than, I can't say anything actually positive about the way the current administration is dealing with some of these issues. But even more specifically, now that we have this Star Trek approach in the United States and the Sputnik space race approach from Russia, we're making this into a science fiction, which is not what good public health is, and is not the kind of medicine that we want to practice, and certainly is not the kind of dialogue and communication that Wally and Walter and all you guys have been doing so well. So I'm hopeful that we can dig back down and find it, but it's not getting better with this current administration.
Yeah, and there's a lot at stake now, right? I mean, we're having conversations about warp speed and the mistrust that the Black community has generally, and I think it was very enlightening because you mentioned it's not just about Tuskegee, but it's about their interaction with the healthcare system on an ongoing basis. But there's a lot at stake, right? I mean, we know that Black Americans are disproportionately impacted by COVID, they're more likely to get it and they're more likely to die. So as we have this debate and we talk about trust or mistrust in the system, the medical community and the vaccine, what are the potential impact? What's the impact from that? If then collectively Black Americans say, you know what, I'm too skeptical, I'm not going to get it, or I'm going to wait to get it. What do you think the implications of that would be?
Well, it could be horrific. I mean, vaccine will do nothing for COVID-19. Vaccinations is what matters, right? So not having the vaccine, but rather getting the vaccine deployed and getting people to actually accept the vaccination. So if we can't get enough people to take the vaccination, we're going to continue to see the carnage that we're seeing right now. You know, earlier in this pandemic, when New Orleans was one of the epicenters back in April, you know, I made a comment that the way that we're dealing with this pandemic, we're going to have this macabre game of whack-a-mole, where one state's going to have a flare up, so New Orleans is going to flare, then New Orleans will get better, and then Texas will flare, and then Texas will get better, then Florida will flare. It'll just continue, and this virus is going to just circulate around the country and doing this. So, you know, what we need to do is first of all, we need a national strategy, and that national strategy needs to include clear and consistent health communications messages that are unequivocal and easy for people to understand. And we have not had that at all from the very beginning with the equivocation on whether or not people should wear masks. So I'm sorry, I'm getting these phone calls. I'm sorry, that's where we need to be. We need to be in a national strategy and not a local strategy.
Dr. Radin, thoughts? Want to make sure you get in here.
Yeah, clearly from a population level, if certain communities aren't getting vaccinated, they're going to continue to see higher rates of infections, and certainly encouraging the communities that are highest at risk, building up herd immunity will be the key for driving down the transmission rates.
So let me ask another question then. Like, clearly this is a huge debate, right, on this topic. Why do we think that Black Americans has disproportionately, been impacted by COVID-19? Like, why do we think that's the case?
I think we're more likely to be infected because we're more likely to be in occupations that are essential occupations that cause us to be out, and therefore we're more likely. And the very first data came out for New Orleans and looked at where the cases were. They were almost exclusively in the New Orleans East area, which is almost entirely African American, and so that's where the cases are. The issue of underlying conditions of hypertension, diabetes, and asthma, you know, that's been out there. And early on, I remember the Surgeon General making a statement about that and saying African Americans need to take better care of themselves, and because we have these underlying conditions is why we're dying. That never made any sense to me at all. If you knew the basic epidemiology, that would just not make any sense, because here in the South, whites have an extremely high rate of hypertension, obesity, diabetes, every one of those conditions. And the race disparities in those conditions are not nearly big enough to generate the disparities that we're seeing in COVID-19. So I think it has more to do with sociology and geography, the fact that we are a racially segregated country, and people are experiencing the country through segregation. This disease is spread through through physical proximity. And if you live in communities that are alike in terms of race or ethnicity, it's more likely that you're going to infect other people of the same race or ethnicity.
Yeah, you bring up a really good point, Dr. Leese, and I'd love to hear your perspective and the perspective of others around, you know, there's also a debate that's connected to this, right? Which is who should get it? Like, how should they prioritize? And that's a debate that's ongoing, both at the government levels and, you know, community levels. Like, who should get it first? Is it the elderly? Who's most at risk? And to your point, if it's Black Americans who are more at risk, not because of some genetic or, you know, chronic disease condition factors, but it's because they just happen to be out there in their communities and they're on the front lines in many ways, then should they be prioritized as a community because we see that they're more likely to be infected and, you know, potentially even die from it?
I think this is a great dialogue that needs to happen across this country. But it's not just because it's first doesn't mean it's going to be best. There'll be multiple type of vaccines. Some are going to be injectables, some may be oral, some may be nasal. Which ones may people want? Will it have the effectiveness? There's so many unanswered questions. And if we rush to judgment or rush to get information out there that's not accurate, we're going to even have more erosion in trust. I am really concerned about what's happening right now and an election surprise or whatever else might end up happening during this debate. It shouldn't be a debate. We have a regulatory framework, we have an FDA, we have a trusted CDC. We've pushed a lot of that aside. We need to also stand up and to answer one other question, physicians and people who are engaged as the intermediaries. African Americans and other minorities have not even been equally represented in clinical trials for not only vaccines, but for cancer, for Alzheimer's, for a variety of pieces. This has been a long-standing disparity issue that we need to deal with. We see it in maternal mortality, we see it in infant mortality. It's unacceptable, but we have to have a voice that's at the level of understanding and not look at just one piece. We need to have a movement, and we're trying to get something engaged in the vaccine part, but this, what you've been doing here is just terrific to hear. I'm sorry this is not in person, but what we can do on Zoom and on YouTube, I think you're the experts in how we get the message out there and get people engaged.
And I want to double click on that, Dr. Ratson, and Dr. Millett, you're on the front lines, you're working with patients every single day. So my question is really centered around how do we do better in terms of communicating? I know that there's been some articles written about how should the pharmaceutical industry think about making these vaccines once they're available more amenable to people, and how do we get people to be more accepting, all Americans, simply because, again, we've talked about they're being developed so quickly. But especially when we think about the communities that are already skeptical, we talked about that. What should we do? How should they communicate so that people are accepting and they feel like they are safe and effective and they should be considered to get them?
Mute. Okay. Can you hear me?
Yes, we can hear you now.
All right. So one of the things first and foremost, we need transparency, and that's really important. We need all the data that talks about efficacy and safety of vaccines as well as other medications, because we also talk about antiviral therapy as well for COVID-19. And it needs to be broken down so that someone who has a low health literacy level can understand. That is the big problem. I noticed that on social media when people just I did my research and they don't really fully quite understand the scientific articles that we are accustomed to reading, because we're trained to read these articles and interpret it and may disagree to agree. But a lot of times I have to explain to them that that's not what it means and what these numbers are. And so I think that we need to take a hold of that so that we as physicians and other allied healthcare professionals can review this data with our patients and our loved ones and our family members. And that way they can have a better understanding of what these clinical trials mean. One of the things that I do I work at a level 1 trauma center in Brooklyn. And when I'm able to, or if I'm allotted some time, what I do is that when it comes down to patients inquiring about medications or a little skeptical about certain medications, or even vaccinations. I'm not a primary care physician. I only specialize in emergency medicine and trauma. What I do is that I also bring in Black history facts. For example, I was on a very popular radio show on Sirius with the Karen Hunter Show. And there was a talk about vaccine. This is at the height of the pandemic. And a listener came on there and said, well, we all know that viruses and vaccines don't correlate. I just let him talk and continue to, state his point, because I know, for one, he's not an expert. 2, he's anxious. 3, he's scared, and he has a lot of concerns. So you got to give people a chance to express themselves or what they think, even if you think, it might not be, it may be pseudoscientific. But one of the things that I had to point to him is how much that we as Black people had contributed to medicine. And the example that I demonstrated to him on the radio show is to talk about an African-born slave named Onesimus. Onesimus was a slave that was kidnapped, brought over to Boston from Ghana. And his slave master was a minister, a Puritan minister by the name of Cotton Mather. Cotton Mather, you could look this up. In 1721, there was a huge outbreak of smallpox in Boston that was killing thousands of people. What Onesimus did, as an intelligent Black man that he was, is that he talked about what African people did in medicine and how they were able to protect themselves from diseases by inoculation. So what they would do is that they will take the pus from someone that was infected with smallpox, rub it into an open wound of that person, then that person developed an immune response, and they were able to be protected from that particular virus for a certain length of time. It is a practice that's been happening for centuries, dating back to Africa, to various parts of the region. And it was called variolation or inoculation. And so he, by all means, did not get credit for the vaccination for smallpox because, of course, we were considered as nothing but animals in chattel slavery. But he is the person that I talk about when it comes down to vaccination and having people to understand that in order for you to move forward, you have to go back into the past, and that's called Sankofa. And that is something that I would love for us as those who are Black and brown physicians, especially Black physicians, to kind of take history and bring that into the aspect of your practice. Because you'd be surprised, the more that we teach at the bedside, the better that they see they're able to trust us. They see how much are valuable that our history and how much we contribute. And they also, the level of trust even goes up even more. So that's what I try to do in terms of bringing that to practice, because I want us to understand that this is not a new phenomenon with vaccinations. This is not a new phenomenon with pandemics. Pandemics has been in existence for many, many years, for centuries. But we have to see ourselves in ourselves. And if we asking people to be culturally sensitive and culturally competent, we also as a people have to be culturally sensitive to each other and be culturally competent about our history and understand that we also contributed to medicine. Like I said, I was trained in Cuba, and throughout our schooling in Cuba, you had to know Black history. You had to know about Black doctors in medicine. You had to know about your people, how they contributed to medicine so that you can provide adequate health care. And that is something that I see that can definitely help with surviving COVID-19, and hopefully with a safe, non-toxic vaccination that, again, that we have to make sure who's the manufacturer, because I'm very skeptical of which manufacturer. If it's from Meharry College or historically Black college or from Cuba, I'm all for it. But still, we still have to bring that into effect.
It's really interesting. So I got to say, I, for one, will most certainly take a vaccine when it comes up. I will not, however, be one of the first ones to take it, right? And I am very skeptical when it comes to my 5-year-old daughter, right? And what she takes it and when she takes it. So I'll lob the question back at you all then, because you are all experts. Like, how would you give out this? How would you ration out this vaccine? Who would you all say should get it first, second, third, and so on? Like, how would you do that? Curious to know, Dr. Colbreth or Dr. Radin?
Yeah, I think there's kind of two strategies. One is vaccinating the people that are highest at risk, either because they're out in the community getting exposed, either they have different comorbidities that may put them at higher risk. And the second is vaccinating individuals that put everyone else at risk. So there's been a lot of research for flu vaccines that you actually can reduce transmission most effectively by vaccinating young children, because those are the main drivers of infection. So I think there's kind of two strategies here. One is who's going to transmit it and where can we block those transmission chains, and also who's at the greatest risk of having these severe complications.
And I think the skepticism that we see in the community, sometimes there's unfounded skepticism and then there's well-founded skepticism. And the skepticism that we see in the community, I think it's well-founded. Vaccines typically take, the average length of time to get a vaccine is around 11 years, typically. So this Operation Warp Speed is taking us into less than a year to try to get to hopefully a safe and effective vaccine. We look at something like chickenpox vaccine, took over 34 years to develop. So this is a very well-founded skepticism. And I think we have to use caution. I think Dr. Millett brought up an important point that we have very good and very strong medical centers that are at historically Black colleges, Meharry Medical College, Morehouse School of Medicine, Howard University, and having trials that are conducted by the community, within the community. And there are amazing African-American vaccinologists that are working on vaccines. I think if we can demonstrate to the community the participation of the Black community in both the development of the vaccine and then the studies and the trials where the vaccine has been studied, I think that will start to build confidence. And then we can begin to look at how we distribute the vaccine into healthcare workers, into communities that are at higher risk for developing infection.
So let me ask a question then, like, there's so much information out here, right? I feel like I go online on Facebook and my friends are saying one thing. I go on CNN and they're saying one thing. You go, I'm not gonna say I go on Fox, but I'm sure you go on Fox, you see another thing, right? Like how do we know who to trust, right? So when that vaccine comes and that person is sitting at home thinking, should I do this or should I not? How do we make that decision, right? Especially people of color.
I think we have to sort that out. I think an excellent question. Dr. Muleta just brought up a really good point when she introduced the idea of health literacy. There's again disparities on health literacy, and there's lots of issues that we need to figure out of how to deal with that. And there's been a whole body of research on that. But we've introduced a new term for vaccine literacy. And it's not necessarily just a term, it's also a way of how you think about it. So you know how vaccines work, you know why they're important for the community protection. Like we have a fire department to protect against the community. We don't have talk about it like that. Then herd immunity, which is an epidemiologist scientific term. We've got to start to put things in terminologies that people can understand, and then they know who to trust. So they'll know whether it's their church, their local school of public health, their local medical facility, academic center, historical Black university, all the different pieces that we've been talking about, I think are key to figure in. And also to create channels that are trustworthy. I think that's what you've tried to do here, to be able to help people sort through. So it's not 1, 2, 3, they say, so I believe what they say on social. You've got to figure out a way to do it. And I think it is possible to do.
Also I've worked with a lot of community activists. That's another thing that was really important, what happened in New York. And
something odd is going on with your audio. Sounds a little.
Me? Is it me?
Yeah, a little bit of a weird static thing behind it.
Do I sound better?
It's kind of the same. I mean, we might be able to get through it, but go ahead, try.
I'm so sorry about that. These are child, this was $5. I couldn't find my other one. Sorry. What I was going to say was that one of the things that I've learned at the height of this pandemic, as we all know, is very tragic. New York was hit the hardest in the entire country, and it was quite devastating. One of the things that was not expounded in various media outlets that we had to do in various parts of Brooklyn, as far as the Black and brown communities, and especially in the South Bronx and even in the Harlem. Can you hear me? Somebody.
It's a little. Maybe pull out the headset and try without the headset. Sorry, you sounded perfectly fine.
Can you hear me better?
Oh, perfect. Great. Yes.
Cheap headphone. Sorry.
Go for it.
One of the things that we where I currently am employed as an emergency physician, the majority of us are Black, to be honest with you. And one of the things that we had to do on our own is speak with community activists, whether it's through social media or even in person when they brought their family members over to our emergency department. And the reason why that was really important, because between these community activists as well as leaders of faith-based religions, they are the pillar of the community. So once we're in contact with them, we're like, listen, we have to have people stay home. They can't be having parties. We explain everything, what's going on. We could show you little clips on the low, what it's like in the emergency department. But we need our people to remain safe because nobody is coming to us to save us. If you work in a public, underfunded hospital like I do in New York City, and New York City is very segregated in healthcare. Everybody thinks that New York City is integrated, but when you talk about the different area codes, it becomes very segregated. You see the haves and the have-nots, and we talk about race disparities. We got to also include institutional disparities. So working at these public underfunded hospitals, we knew that we didn't have any, we were limited with resources. As a matter of fact, we ran out of vents and oxygen tanks and even blood tubes and IV tubes, where that other private hospitals were able to receive financial backing and other resources. So what we had to do our best to save the same community that we serve, was to get in contact with all religious leaders of those communities and community activists, for them to be an advocate for people to stay home, be an advocate for people to take better care of themselves during this pandemic. If your loved one is sick, send them to the emergency room, look for signs and symptoms, monitor these symptoms. And believe it or not, even though it's not expounded in various media outlets, that really helped decompress our emergency department somewhat, even though the volume was very high. But that taught us right then and there that we have to do better. The community, as well as the healthcare or the medical society, have to do better with communication, because it's not always just about the medicine at hand. Sure, we live in the United States, one of the richest countries in the world. I've worked in various parts of Africa where you're not going to have doctors or access to hospitals and medicines and vaccinations, certain parts. I'm not saying all over, because that's a stereotype. But what I'm saying is I've worked in underdeveloped countries where that's not the case. But because we were working in underdeveloped like conditions, we had to be creative, and that means that we had to work with community activists and those who are the pillars of the community to help us save our community. So that means that we have to do a better job at communication. Again, it's not always about the medicine, it's how you interpret it, it's how you communicate. And I'm a big advocate of that. And so we went on social media and started talking to the people on social media, the importance of staying home and what is happening in the emergency departments. We went and I wrote for New York Daily News and asked people, if your family member is coming to the emergency department, please pin a letter or something with contact information, list of medications, because we might not be able to contact you per se because of what's going on. And believe it or not, it helped dramatically in our emergency department, because we were able to communicate with family members on social media, on the phones, and that way they took better care of themselves, because they know, man, my loved one is in the hospital, let me stay somewhere else, or let me do better by wearing a mask and staying home unless I have to go to the store. Again, institutional disparities is a big problem. When you come to a hospital that don't have the limited resources, what do you think is going to happen to people? And that's a big problem. And we don't talk about it. We talk from a patient perspective, but we're not talking about how the communities are not being really invested in, even in our own hospitals. And that's the problem that I've seen on the first line, of being on the front line from March all the way to the last week of April. And it was quite devastating. And I pray that I don't ever go through that again.
Yeah, it's a big topic for sure, right? When we talk about healthcare disparities that are systemic in the system, and that leading to a lot of the mistrust and a lot of the disparity in outcomes and care, it's a really, really big issue, Dr. Millett. And obviously what you said is you expressed it really well and you gave specific examples. So one of the themes that I'm hearing though come through from you and also from our public health experts is this idea of communication and going through trusted sources and really digging in with the communities to make sure that we understand them, the medical community, the industry understands them, and they really want to dig in to help and overcome some of that. So I think that that's kind of a theme that's coming through, and that's one thing that potentially can help overcome some of the mistrust that exists systemically. So go ahead. Yeah, Dr. Colbert.
I think with the communication piece, what I know I have a challenge with, and I think we saw this challenge show up from the beginning of the pandemic. Somebody brought up the ambiguity about whether or not we should or shouldn't wear masks, is how do we deal, science is messy. It's not like the movies. You don't just produce one vaccine and the vaccine works and now you distribute it. Science is messy. It takes time. It takes work. It's hypothesis driven. We ask questions, and the more we know, the more we change the process. And so what I have a difficult time, and I'll maybe ask a question of my fellow panelists, is how do we help to communicate the ambiguity of science, the continued quest of science, where an answer that we believe is true today, it might change tomorrow, and that's part of the scientific process. I think that's one of the biggest challenges that I face. And how do we communicate, especially with vaccines? We did not get the communication right when it came to masks. We definitely, I think we failed that communication. How do we get that communication better when it comes to vaccination? It's something I really struggle with.
I think you're asking a really, really important question that, those of us that are trained in science, we're trained to question everything. So we're trained to equivocate. But the problem is that when you're talking to people about something as important as this, the last thing we need is, on the one hand, this, on the other hand, that. That's a recipe for disaster. You need to, you need to be transparent and say, listen, this is a novel virus. There's a lot we don't know about this virus. There's still a lot we don't know about this virus. But based on what we know, this is the advice that I would give you. I was on a call, something similar to this, when back in March, I think, and someone asked the question. This is somebody who's not in the health sciences at all. Asked, well, should we wear a mask or not? I don't know. What should we do? And one of my colleagues started, well, we don't know, but the N95s and whether, and I just said, look, if you got a mask, wear the mask. I don't know if the mask is going to stop the virus from getting into you, but a mask is going to signal to everyone around you that we are in the middle of a pandemic and we need to be careful. The mask will stop you from putting your fingers in your mouth. The mask will stop you from putting your fingers in your nose. So wear the mask. There's no harm. So what we have to do is we have to take these messages, we have to simplify them. We have to be clear and definitive. And on the one hand, on the other hand, is the absolute worst possible thing you could be doing right now. So that's the way we need to message to people. But we also need to trust them enough to let them know that, listen, this is science. This is a new virus. There are a new thing. There are things that we all think right now that next week we may learn something new and say, wow, we were wrong. We need to be honest about that and say, yeah, we are still learning, but based on what we know right now, this is what I think should happen. And be prepared to come back and correct that next week if new information comes out.
Right. So a lot of folks, vaccine researchers are actually saying that they had stated that they want to be sure to include, as we've said already, Black people in their vaccine trials, given that the Black community has been so, impacted. So what does that look like, right? So what should we be looking at in these clinical trials that will make us believe that, yes, this works for us. Yes, this is okay. Yes, this is safe to take.
I think the key is going to be the phase 3 trials. The phase 2 trial was not diverse.
Can we maybe just talk about what a phase 1, 2, and 3 trial would be then? Because you said the phase 3 trial, right?
Yes.
Is that what you? Okay. Just so we have a greater understanding of what those are.
Okay, I'll give a really quick Wikipedia version. Right?
Yeah, please.
Phase 1 trials is what trials that we used to refer to as first in man. Now we call it first in humans, right? So this is when you, for the first time, introduce this new drug into human populations. Phase 1 trials are done on healthy volunteers, and there you are mostly trying to figure out the dosing and the safety, safety of it. Usually the samples are very small, and that's what phase 1 is. Phase 2 trials are a little larger, and there you're testing the drugs. Typically, you're testing it on actual patients, and you're trying to understand the efficacy and whether there are side effects. And there, the sample is going to be a little bigger, maybe 1,000 or so people. Phase 3 is when you go to a much larger sample, much bigger sample, and there you're looking at you're assessing effectiveness, you're assessing side effects, and you're looking at a bigger sample that should be reflective of the people that are going to actually get the drug. And this is important with a vaccine because a vaccine is a drug that you're giving to healthy people, right? So if you've got a relatively small rate of adverse effects coming from that drug, even if just 1% of people are harmed, 1% of 330 million Americans is a lot of people, right? So that's when you need to test this. You're testing the safety, efficacy, and you're also looking at the side effects. And there you want a big sample. I would hope, I haven't done the analysis here, but off the top of my head, I'd say that these trials need to be 25,000 people or more, and hopefully, even bigger than that, because you are going to be deploying this drug to a lot of healthy people. there is a phase 4, and I won't get into the weeds here, but that's really, once the drug is out, you should still be doing surveillance to determine whether or not there are additional maybe side effects with very small prevalence that would not have been detected in the smaller studies.
I would just like to add that as far as making sure that, as far as the diversity or the backgrounds of people who will be a part of these clinical trials, my opinion is that we need to see studies that show a diverse background of various individuals of different ages, of different health conditions and similar health conditions, including Black people and Latino and various backgrounds. Because if they receive this vaccine, that will also help the public or our community at large to have a better trust in terms of the vaccination or any medication. So diversity is really important in clinical trials, because it doesn't show that, okay, one group of people are being tested on or one group of people are being excluded from these clinical trials. Another thing that is important that I realize that a lot of people say on social media as well, especially when I communicate with people on social media, performing clinical trials does not only happen here in the United States. Even on my beloved island of Cuba, clinical trials are conducted. Okay, they go through the phase 1, phase 2, phase 3, phase 4. It is not just the United States, because it is a part of our healthcare. And so we need to know, does this drug work? Does this vaccination work? Who does it benefit more? Who fits the criteria to be able to withstand this drug? And there's so many things that go involved. So I really don't want people to think or just believe that it only happens here in the United States. I know historically, again, we were guinea pigs for various experimentations, like my colleague said earlier, outside of Tuskegee syphilis experiment. But we also have to get to a point where that if you have Black physicians that are advocating for us to, I don't want to say just partake in the clinical trials, but also receive fair treatment, and as well as to receive treatment for COVID-19, because we were disproportionately affected, there has to be a level of trust. And that's the problem that we have. I think there's also the healthcare disparities can also be extended to medical school. Again, here in the United States, well, I believe that Black African-American students only represent 5% of medical students be admitted, accepted admission into medical schools here. Whereas back home in Cuba, everywhere I look, for the most part, they look like me. And so that made me think to myself that there is a level of distrust, because none of us don't really see us. And so the more transparent we are, the more that we have these type of forums that you are conducting right now, I think that also go along to trust and really take advantage of social media. I hated it. I hated social media initially when I came back from Cuba. I didn't understand it, but I do believe there's a certain power to it. And if we utilize it correctly, we can seriously have a major impact on our community, the way they think of things, how we think of ourselves, how do we take better care of ourselves, the clinical trials, and so forth and so forth. So these forums are definitely perfect to discuss these clinical trials. And there are questions that are from several people who are now interested to really fully understand what that means. And we just made a great impact just now.
Yeah, exactly. You bring up a really good point. I think it's really, clinical trials, people always are looking for, does this work in us, right, as Black Americans? And, we work in the industry where often there are not a lot of Black people or people of color from various ethnic and racial backgrounds represented in clinical trials, but yet they suffer disproportionately from a lot of the disease conditions that these, treatments actually are for. So, we talked a lot about communication before, but I think that there's work to be done to get people, especially Black Americans, accepting and willing to be a part of clinical trials, because there can be a lot of good that can be done as a result of that. But there's work to be done to get them to feel safe and comfortable because of all the reasons that we talked about earlier with the history. So I'd love to hear if folks have a perspective on exactly what we should be doing to help them understand that it could be for the greater good of the community for us to be represented.
Yeah, one example I'd give is maternal health was brought up a few times, and pregnant women have historically been excluded from clinical trial research, as well as women of reproductive potential. And because of that, there's such a huge lack of knowledge of how drugs work in these populations. And the same thing goes along with Black and African-American communities. If you don't test them in the clinical trials, you're not going to really have that information to take to the communities when it's time to vaccinate.
Yeah, I mean, this is a real issue. I mean, the whole systemic issue of vaccination in general. HPV, a cancer preventing vaccine, does not have the penetration equally across this country, and particularly with African American communities. The other issues that were brought up of overseas, you know, we don't want to just experiment, use that word. A vaccine's not supposed to be an experiment on a population, although we might, that might be science speak. We need to figure out ways that we're showing that this is to have the benefit. We need to switch some of the language. And I think what Dr. Levis said so well is that we need clear messages from trusted leaders. The face mask example, you had a perfect answer to it. Why couldn't the Surgeon General say that instead of tweeting out, don't buy face masks, don't wear it? Why couldn't President of the United States say it? Why couldn't governors say it? Why don't we have simple mandates, common sense mandates that, you know, if you go into a restaurant, you go somewhere. I believe some of it is a failure, I would say, from the academic side. The academics haven't maybe been loud enough. The clinicians have not always been there, except, you know, Dr. Milletta's unfortunate, you know, the challenges that she faced, and I had a lot of students that were not physicians, but others that were frontline workers, and just to hear that the fear in New York City, I think the whole piece needed to be dealt with differently. Now we're trying to pick up the pieces. This vaccine literacy idea, we've actually put together an acronym called CONVINCE. So how do we have COVID, new vaccine, information, communication, and education? And we're trying to get a campaign together with both businesses, with non-governmental organizations, civil society, physicians, all sorts of health intermediaries, and retail stores. Where's this going to be delivered? Is it going to be your local Walmart? Is there such a thing as a local Walmart? Although they're the biggest private employer in the country, there are places that we need to start thinking differently and acting differently. And I think, you know, what's been highlighted by, you know, everyone here, and Dr. Colbreth's giving her examples of the need for communication. I think we all are part of the solution, and hopefully identify the activities that we can do together.
So I have another question too, because I'm really interested in digging into kind of the science of this virus a little bit more. And I'm curious to hear from our epidemiologists and infectious disease specialists and public health experts around the concept of herd immunity. And if there is a population of people, and there will be, right, who choose not to get it. And we know that, you know, the virus is, we talked about this before, it's increasing and it's going down. And we expect that there's going to be kind of the ebbs and flows and the peaks and the spikes, and for a while, until we have sufficient kind of vaccination levels. What happens epidemiologically in the country if we continue to have these spikes, and then we have a large group of people who don't get the vaccine? Can we expect at some point that will reach the point of herd immunity? And for those of the who are watching who may not know what that is, if you could just kind of quickly explain that, and I'd love to hear kind of your perspectives on that.
So
Go ahead.
Well, I actually anticipated this question, and so I actually did do some calculations of what we would need to reach herd immunity. So, and I'm happy to share that. But first, what is herd immunity? So the way to think about think about it conceptually, right? So let's say we have a vaccine, and let's say the vaccine is effective for 90% of the people, right? So that means that there are 10 people who the vaccine does not work, doesn't help for some reason, or they have what we call a counterindication. There might be some reason why they can't take the vaccine. Maybe they have another health condition that would make the vaccine too dangerous, or they're on other life-saving drugs that would not interact well with the vaccine. So let's say there are 10 people in that category, so they cannot be vaccinated. The other 90% can be, right? So the idea of herd immunity is that if you are part of that 10%, and the people that are around you are all vaccinated and therefore not infectious, then even though you are still you are not vaccinated, you are still going to be protected from getting the virus, because the people around you are not going to transmit it. So that's kind of again a Wikipedia version of what herd immunity, the concept.
Thank you.
So what percentage do you need to it really depends on what we call the replication rate. So how many people does a given person infect? So the more people one infected person will infect, then the more people you need to have be vaccinated in order to have herd immunity. So I tried to look this up. I said, well, what is the replication rate? And honestly, the estimates are they're all over the place. They are, in some countries, they are reporting really low replication rates. In other countries, they are reporting really high replication rates. So I would have to say, I feel like my colleague with the whole equivocation thing is, I don't know what the replication rate is. But assuming that it's a low end, which was around 2.2% was the lowest that I found, you would need 54% of people to be vaccinated or have immunity to have herd immunity. If on the high end, which was the highest I found, was 6.5% replication that I found in one country. If it's that high, you would need 84% of the population to be vaccinated or have immunity in order to have herd immunity.
Wow. Dr. Radin, what do you think?
Yeah, I think the whole idea of herd immunity and communicating this idea to the community is really important, that it's vaccination isn't just to benefit you individually, but really your whole community. And as was said, the replication value is going to be influenced by so many factors. Still, it can be influenced by how many people are still wearing a mask and socially distancing once vaccination starts. And all those factors can change it quite easily. And I think another key part is communicating that it's, even if you do get vaccinated and it isn't entirely effective, the vaccine could also prevent potentially that you go to the hospital or you get these severe complications. So it's not either a black and white, you get infected, you don't get infected. It's kind of a gradient. You might still get sick with COVID, but it might not be as severe as it would if you didn't get vaccinated.
And herd immunity,
so much.
Another good example of horrific health communications, herd immunity, as opposed to calling it something like community immunity, which would be more descriptive. It's like social distancing. Another thing that my head's been exploding about this. The last thing we want is for people to be socially distant. What we need is social connection, right? If people had more of a sense of social connection, people would be more likely to say, I'm going to wear this mask because it might stop me from infecting other people. What we want is physical distancing, not social distancing. So whoever came up with that messaging, again, I truly hope that they were not trained at one of the accredited schools of public health, because it worries me. Herd immunity, social distancing, and I forget what the other term was, but these terms, a warp speed. Whoever came up with these terms are just, I hope they're not people who are actually trained in public health.
Yeah, I think that communication part, right? I remember when I was pregnant and I let my family know, if you want to be around the baby, I had to get a pertussis vaccine, but you getting a pertussis vaccine booster is going to keep the baby safe. And I mean, the whole family, it was like, line up, let's go get vaccinated because we want to be part of community. And so some of this communication about vaccine, it's about, this is what the community and how the community is supported. It's the same thing with wearing a mask. Wearing a mask, it's protecting you from me. It's about the community, and we can't have this individualistic approach. And I think, unfortunately, with where we are so much as a society, it's all about me. But whether it's about vaccines or wearing a mask, it's about us. And we have to love one another enough and love our country enough, love our community enough so that we would do these things that may be a little bit inconveniencing, but it's about the community. And that messaging is just not coming across.
I would say from New York, from being up here on the front lines of New York, and I'm not saying that New York did the perfect job, but we damn near did the damn thing when it came down to being aggressive with, dealing with this pandemic, although there were many mistakes that were made. One of the things that were promoted up here in New York, and it may not been disseminated across media outlets, was that we were promoting that people love each other and love on each other during this pandemic. And we actually did change from saying social distancing to physical distancing. And so, but even with that, the community overall, I think sometimes we underestimate the people in the community because they became creative. And what I've seen, like I said, up here in New York, I can't speak for anywhere else, they became creative with how they can still keep in communication with their loved ones without physically seeing them. And the community came up with the idea of Zooming, not the doctors, not other experts, the community up here in New York. And I've seen this personally on hand with Zoom parties. It's because people were still longing to see their relatives. So a lot of us started getting engaged in Zoom parties. And that really helped a lot because people after a while started discussing COVID. Okay, who needs who needs bags of food? And this was happening up here. Who needs bags of food? Who needs this? Who needs medications? Who can be one person that could designate themselves to pick up medications for grandma, auntie, and so and so. So the community, it went back into the hands of the community. And to be honest with you, although, you know, Governor Cuomo is my governor, and I may not agree with everything that he said in the past, but one of the things that he definitely did, he promoted that community for people to come together as a community to help each other out. And that was by wearing masks, checking on each other on social media, doing things to make sure that the next New Yorker was not missing out upon. And I'm not lying to you. It really helped us handle this pandemic. And so we had to change our language too, whether we were speaking on the news or CNN or we were doing these forums, is to promote people to be kind to each other during this pandemic. And we definitely pulled through. And I'm saying this, yes, as a proud New Yorker, but I'm saying this with being on the front lines and seeing it on hand. When that message came through that for us to be kind to one another, it helped so much that to the point where people were helping the emergency department, people donated tablets to our hospitals. People were donating their phones, new phones, to our hospitals so that they could communicate with their loved ones because we didn't have the funds. And that is a big deal. Again, it goes back into communication. The whole theme of this conversation is not just about COVID, it's about communication.
So one other thing that I wanted to, all the physicians here and PhD experts, you know, there's a lot of discussion in the media around the race. We talked about that, right? Warp speed. But there's many, many manufacturers that are racing to get vaccines to the market as quickly as possible. And then lo and behold, the other day we heard that Russia has one available. So, you know, as people try to weed through not just, you know, what should I do? Should I get it or not get it from the pharmaceutical companies that we know of that are reputable and have been, you know, entrenched in the science of vaccine development for many years. Then you have the Russian vaccine. So there are going to be a lot of decisions that patients and people in the community have to make around which one, what's true, what's not true. Any comments you have on that? I mean, because there's already a lot of disinformation and a lot of skepticism in our communities. What do we do now? Russia's got one, apparently.
I'm waiting for Meharry or Cuba, because if I got to go back to Cuba and bring my family down, that's what I'm going to do. But I'm waiting for Meharry College of Medicine or Morehouse to develop a vaccination or some type. I'm sorry that it may sound like I'm being biased, but I trust my people. I trust my community. I trust that we're going to do right, not only for each other, by each other, and for many. And so there are wonderful Black scientists and that are on the front line to find a cure for COVID-19. I think the problem is that, you know, this is old saying, not even an old saying. There was a time that I remember a patient had said, well, I prefer a white physician. We have to get out of that mentality. We have to learn how to trust the people who are taking care of us. And so for me personally, I think that what's most important is really do your research on who the manufacturer is. I'm sorry, right now, I'm not too keen about Russia's vaccination, especially with the history between the United States, especially with Trump in office. Again, I prefer to wait until a respectable institution like Meharry or Morehouse or Cuba to come out with, because I trust those institutions. I trust Cuba. I trust that they're going to do well, and they're going to stand by us and making sure that we're not harmed by the vaccinations or any type of treatment.
I really need to respond to that. And I'm responding now as a former Meharry Medical College professor, okay? That it does not have to come from Meharry only. It needs to come from a reputable and trusted source, but reputable and trusted sources are not only the historically Black universities and colleges. Certainly a vaccine from Meharry, I would be very happy to take it and I'd be in line to do it. But I think a well-produced vaccine coming from Tulane, which is where I am now, I would also take as well. So I think the question is whether or not the process of developing that vaccine went through the normal standards and a normal process that we use in the FDA, which usually takes, on average, more than a decade to do. But you can move quickly without cutting corners. And if they are in fact not cutting corners, I think the key is going to be what comes out of this phase 3 trial. If the phase 3 trials are done properly and done with sufficiently large samples and it's given enough time to actually go through the process of determining whether or not the vaccine is working, I would trust it as long as it's coming from a reputable institution. I agree with you on Russia. I'm a lot skeptical about whether Russia's sudden declaration that they have a vaccine is something we should trust. But I think that we can trust more than just Meharry and Morehouse. And I absolutely love Meharry in my experience there.
Yeah, I agree. I'm a little worried about the Russian vaccine and that it could potentially reduce trust in the community in other countries if this vaccine was rushed through the process and might have safety problems. And I think I trust the FDA process as long as no one cuts corners. I think it will turn out well in the United States, but I am worried about the Russia experience reducing trust here as well.
So this has been an incredibly informative conversation that we're having here. So we do need to wrap now, but I think what I'd love to do is go around, right, and just get like a minute, like 60 seconds from each of you on just last thoughts, right? We have a good amount of people here that are actually streaming through YouTube and some folks that are streaming here through Zoom. We would just love to get any last thoughts or anything you'd like to leave the folks with here that are actually watching and might perhaps be on the fence. Like, how would you lead them to believe that, yes, this is something you should be looking forward to taking, or maybe pause for a bit and do this little bit of research first? So anybody want to take that? We'll just go around and make sure everyone gives an answer.
Yeah, I'd like to take that because somebody just actually put a question in the chat that I thought was really an important question. The question was, how do we know if they've been cutting corners? Yep. Now, much of what's happened in Warp Speed has been done in secret. So we don't really know all that's going on through this Warp Speed process, and that is problematic. But there are many of us, including people on this call right now, who are monitoring what's happening, who are involved in what's going on, who are part of the process. And those should be trusted voices, people that are participating. Those of us that are in the room when some of these decisions are being made, as I am in some cases, we need to be getting into the media and we need to be writing about it. We need to be putting out op-eds. We need to be making statements so that people do know that, in my opinion, this is a vaccine, or this is a vaccine that I'm willing to take. And I would commit to actually writing a piece and making that statement when there is a vaccine that I personally would be willing to take myself or give to my loved ones.
If I have the opportunity to echo Dr. Levis, then I will commit to write that with you and support it after it's been through the right process. I think transparency is key, and 100% we've had regulatory systems that have worked, and they've worked for medicines and vaccines in the United States and throughout the world. I've been in 4 different sectors. I'm a public health physician. I've been in academia. I work for not-for-profit. I work for the US government and then private sector, including a big pharmaceutical company that's having a lot of public relations right now that they have a vaccine that will make it, and it's not even in phase 3 yet. So I think we all need to understand now that we're all in this together. And how we get out of this is going to be how we communicate, which has really been the theme here. So my piece is, how do we get out of this together? How do we, if Dr. Fauci said the vaccine is the showstopper and that's what we need to figure out how that showstopper will make its way. As Dr. Levis well said, it's not the vaccine, it's the vaccination or the immunizations that are actually the level that we need for this community protection. So I appreciate the time for the charge here. Also, let me say, the last thing is you don't just have to come from a school of public health to be a good health communicator. So, Wally and Walter, I know you probably don't have public health backgrounds, but your whole Black Health Now and this whole movement is excellent. And we need to keep the dialogue going and move in that regard. So, whatever I can do and others, I'm happy to keep this going.
Thank you, Dr. Radson.
No, I think that's absolutely correct. I was actually thinking we may need to come back. I know, my mom taught me you're never supposed to invite yourself to a party, but maybe we need to invite ourselves back to the party again as more data emerges. Too often, even with treatment, There were treatment announcements by press release that the papers hadn't even been published yet, right? And there wasn't even data yet for us to analyze. It was just the press release. We can't have the vaccine information to come out like that. We need the peer-reviewed publication to come out. And when we have that data, I think we can come back and have another conversation about the vaccines that look effective.
I want others to answer that before we wrap, as to Walter's point, but I will officially say you are all invited back. So I just want you to know that, because there's a lot of rich content here and more still to talk about, to your points, Dr. Ratson and Dr. Colbreth. So Dr. Millett, did you have anything that you wanted to add to this? And then Dr. Radin? In terms of final thoughts?
I'm a radical, and I believe in God, science, and health. And I would love for everyone here that is watching this, that, you know, and I'm not imposing my religious belief in anything, but we have to learn to be patient with God, and we have to learn to be patient with science and health. It doesn't run on our time. And we have to respect these these microorganisms. But I will say this, that I do have faith, I do have hope. That we will survive this pandemic. It's just a matter of that people need to understand that we have to have patience. We have to let the professionals or the experts do what they do best. And I'm not saying that we just leave everything in the hands of these individuals. Of course, you want to inquire, you want to learn more about it. But I think that even on the side of being an activist, that we also have to do better from the medical community, is really reaching out to community activists and religious leaders and even educating them, perhaps, you know, teaching them ways to teach health, because we can't do everything. Or, you know, we also have to bring that in, because public health is really important. It's not enough funding in public health. And this is why it's easy for people to write pseudoscientific articles, spread it on social media, and then everybody believes it. We have to do better with communicating with the community. And one of the ways that we do, we have to step out and reach out to the community. I think that the United States, for the most part, have gone long away from visiting patients' homes. And unfortunately, times have changed where people will have, you know, there's violence more so than ever. And so you have to learn to protect yourself. But with that, we have to learn to figure out creative ways to reach out to our community. And this is how we're going to fight the pandemic. That's just my final thought. And I'm sorry, I don't know what the heck is going on with my computer. Nobody never called me through here.
And Dr. Radin.
Yeah, I just wanted to thank all the other panelists. I learned a lot today. I think also going forward, I really hope that we learn a lot from this pandemic so that we're prepared for next time. I think a lot of the things that we learn for communication are going to apply to many other things in health and healthcare. And I hope it's just the beginning, that we don't lose this momentum that we have with the pandemic. And I hope it continues to help improve communication of vaccines and public health.
Well, look, thank you all so much. This has been incredible. We appreciate your time, your education, your facts, like everything. This is just incredible. I'm walking away learning quite a bit from this, and I can't thank you all enough. So with that being said, this is my final goodbye to the folks here. I'm sure I'll be back again. It's been incredible hosting and working with the TBWA World Health Group, specifically Wally, Brian, Jonathan, Chris, and team. Appreciate you all, and I am signing off. So thank you all. Let's continue the conversation with Black Health Now. This is going to be an ongoing thing. It will never die out because we'll always be looking out for each other and our health. So thank you, everybody. Take care.
Thank you.
Thanks.
Okay, bye.